you're looking at is just really odd, weak breathing like that should be the first assessment. And if not, then you can go on and put your monitors on and your oxygen and things like that. So airway, again, is your first assessment once you get them hooked up. So you should initially assess airway when they come in, and you should be frequently reassessing the airway constantly until they're awake and talking with you. To assess the air movement, our end tidal, the ones with the orange tips back that we use in GI, they do work with these monitors. You can put end tidal on here if you want to put on the nasal cannula to see. You can also just hold your hand in front of them. You can feel them breathing. If you put an oxygen mask on, you can see the condensation in the oxygen tubing, oxygen mask. You just want to make sure that you know they're moving air when they're asleep and not awake and talking to you. Sometimes our patients come in with LMA devices. Those LMAs are just like an oral airway. They just sit behind the tongue just to keep it out of the way to open up the airway for them. That LMA, we could take it out back there, but the reason we leave it in is because it's the best oral airway you can put in. You know that you have a good airway with that. And there's no harm if the patient were to pull it out themselves, perfectly fine. You guys can take it out whenever you want to. You don't have to deflate the cuff or do anything with it, you just pull it out. So we like to leave that in because it gives you guys a good airway until they wake up with it. So oral airway, and we have some new people coming in, and if you haven't gotten to place a lot of oral airways and you want to place them, you can always come back in the OR with us. We'll let you place them once our patient's under anesthesia, just to kind of get comfortable with it. But if you're unsure if they're moving air or if you can hear them obstructing, so snoring is a partial obstruction. So if you hear them obstructing, you can put in an oral airway. If you go to put it in, the patient coughs and wakes up, great, that's perfectly fine. Then just don't put it in, they can't tolerate it. But with our patients, we give a high amount of narcotics back in surgery. Narcotics help to take away that cough and gag reflex. So a lot of them will probably tolerate an airway fine. So you can always put an airway in. You're never wrong to put an airway in for them. And if, like I said, if they cough, just don't put it in. And if they don't, then great, it gives you a nice airway for you. Generally speaking, normal sized women, we use a yellow. Small women, we use a green. And normal sized men is the red top. So breathing assessments. So don't forget, you can put your respiratory rate on the monitor as well as the end tidal on the monitor. So you're looking at quality of respirations. Again, if they're guppy breathing, that's an emergency. You need to let us know right away. Some of our patients come back and they're only breathing, 6 to 8 a minute because of the narcotics. You can always put that respiratory rate on the monitor so you can watch that, or you can do it, calculate it yourself. But if the patient is having really shallow breathing, if they're really weak, so if you lift up their arm and it just falls like dead weight, they can't squeeze your hands, then that's an issue. You need to call us right away. Some are doing the shallow breathing because they're in pain, so you need to assess your pain, things like that with breathing. So we have this new medication here, it's called Sugammadex. So the only paralytic long-acting paralytic we use back there is rocuronium, and Sugammadex was specifically designed for rocuronium. It goes in there, it traps the molecule, and then you excrete it, so the rocuronium cannot work. So you can get complete reversal in about 30 seconds. So it is by far the fastest thing we can get to reverse that for the patient, even faster than intubating. So I am working with pharmacy right now. We have it in the main Pyxis back there. You generally just need one vial for this residual that they would have. I'm working with pharmacy to get it put in your guys' Pyxis so you have it here.
It's here now.
Is it here? You checked it? Great.
Yesterday.
Okay.
They had me check and they had to do something different, but it's in there now.
To get it out.
To get it out.
Do something different?
They did downstairs in pharmacy, but she wanted me to check and call if it wasn't.
Great. So you just went into the patient override and it was there for you? Great. Okay. So if you have any concern that it might be residual and you have the guppy breathing, just go get a Sugammadex vial and just have it at the bedside. And then we can come and assess and give that to the patient. If it's not that and we end up giving it, it doesn't hurt anything, it doesn't matter, there's no adverse reactions to it. Again, if you have that really low respiratory rate, it's because of the narcotics we gave back there, whether it was a very painful surgery, we're expecting them to have a lot of pain here, we want to load them up. As long as their oxygen is okay, just monitor them. I would suggest putting the respiratory rate on the monitor so you can really see it in real time in case you get, charting and can't assess it constantly. I would also recommend doing the end tidal. Doing the end tidal on these monitors, because it's not a closed system, it's not completely accurate, but it helps us trend. So if your end tidal is running at 30, 40, then all of a sudden it's 10, well, we have some kind of obstructing going on. If there's no end tidal, then they're not moving air. So it just gives you an idea of whether they're moving air or not. You can always put the oxygen on them and connect it, and if you need to, put a face mask over it for the actual oxygen delivery, but use a nasal cannula for your end tidal monitoring. We are trying to figure out different adapters and what we can use to make it more seamless. We're still working on that. But as of right now, the GI ones work. If you need one, you can.
We'd have to get it from there. I don't think we have them.
Yeah, so I'm working to see what the cost difference is. Up on the floor, we have the end tidal one that hangs down over the mouth. So we're looking at that versus GI, which one's more cost effective. And then we will look at the adapters too. For the cost effectiveness compared to the nasal cannulas you have here, you'll need to see. But we're working with that we're hopefully going to get something stocked back here, so every nasal cannula you put on, you should be able to end tidal monitor with it. So we're
And this is what you use in anesthesia?
We're trying
So-
them.
This, I haven't used this blue, but you probably will have to get rid of this clear and just use this blue part. I'm not sure if this blue connects with us.
Okay.
This isn't the one they use upstairs. It's a little bit different. But the orange cap ones, those definitely work. I tried them yesterday. I'll check that. We can just plug that in and breathe into it and see if you get the end tidal monitoring. But we want to make it so every single patient, you guys can monitor end tidal if you would like to, because that's really a standard of care now. If they're not awake and they were given sedation, they should have end tidal monitoring until they're awake back at baseline. So we're working on that to make it. But if you have any issues, you can. Also, if the end tidal is showing like 80 or 90, something crazy high, then that gives us an indication that they're probably retaining CO2 if a non-closed circuit's that high. So it prompts us, to get an ABG sooner, to start with that treatment a little bit sooner. So oxygen saturations, we have different categories for it. If they're less than 90% and they're moving air, then just sit them up, have them cough. We have a lot of smokers here, so if they need a breathing treatment, either call for one or one if it was given the okay for. Have them take deep breaths. Increase the mode of oxygen that you're giving. So if they run a nasal cannula, do a simple mask, and then go to a non-rebreather. Just keep increasing your oxygen. If it's a low saturation and they're moving some air, but it's not adequate amount of air, that's when you think about putting in your oral airways, doing chin lift, jaw thrust. Again, if you haven't gotten to do a lot of jaw thrust and you're not the most comfortable doing it in here with the patient, you can always come in the back. Once you have anesthesia, we'll let you jaw thrust so you can see what it feels like. Again, if you jaw thrust a patient, it's painful, it's not comfortable. So if you do it and it wakes them up and they don't like it, great, you're not gonna hurt anything by doing the jaw thrust. So feel free. You can also be to assess, how narcotized they are or how sleepy they are, type of thing, get them to take a deep breath for you. You can also do the chin lift. But if you don't wanna sit and do airway maneuvers, just put an oral airway and that will solve the problem for you generally. Sometimes just moving your head side to side, because it's your tongue that's falling back and obstructing your airway. So if you can just move the head side to side and get that tongue out of the way, you can move better air, generally speaking. So if you have a low saturation, less than 9%, and they're not moving air, that's when you need to call for help. Again, you should be doing your jaw thrust, chin lift, putting your oral airway in. But if they're not moving air and we're already less than 90%, our SpO2 is about a 30-second delay. So if you're already less than 90 and not moving air, chances are we're lower than that already. So we need to call for help, get more hands there so we can do multiple things at a time. You need to put a higher mode of oxygen on them right away, try to get an open airway for them, have an ambu bag, all that kind of thing. If anesthesia is not responding right away or we cannot be here immediately, you can call a code or rapid response if we need to. We generally like, if we can, to keep it here just because we are all trained in what to do here, but sometimes if there's no one available and we need extra hands, we need extra hands. So we'll never get in trouble for doing that. So blood pressure. So this is kind of why we wanted to do this, is just to assess blood pressure measurements. So we get a lot of the bigger patients where we need to do the forearm cuffs. So the forearm cuff should be halfway between your wrist and your elbow, and you'll get a 10 to 20 reading higher. 10 to 20 millimeters will be higher. Again, if the patient is obese, their blood pressure is going to read higher with a cuff than someone that is not. So taking those things into account. Also, if you feel like you have the wrong size cuff on, feel free to change the cuff. If you have a cuff that's too small, your reading's going to be higher. If you have a cuff that's too big, be too low. And so if it's a really high reading, but it just doesn't seem to match the patient, if their baseline, you can look over and same day, if their baseline blood pressure was not really high and all of a sudden it is now and they don't seem like they're in pain, then think of that it may not be accurate. Maybe try a different side or readjust the cuff or do whatever. But if you take it, different places and you're still getting a high measurement, please call us so we can give you something to take care of that. Also, if they're really high and same day and they're back at their baseline here, a lot of times we don't necessarily treat them because we tell them to go home and take their pills. So we don't want to send someone home with blood pressure medication on board and they're going to take theirs, plus they've had anesthesia, and we can potentially get into problems that way. If someone lives at a little higher blood pressure, we by no means are trying to fix everyone's blood pressure here. We're not doing that because we're going to not be monitoring them. So sometimes if it's a little bit higher and we're not treating it, that could be our reasoning why we're not treating it. So hypertension, we generally say systolic greater than 160, diastolic greater than 100, MAP greater than 100. So these are the medications you'll see from us: hydralazine, metoprolol, labetalol. We generally decide what to give based on what our heart rate is. Hydralazine will increase our heart rate. So if we're at a really low 50s and 60s, you'll see us order hydralazine. If they're already at a low heart rate, we will not order a beta blocker because of course it makes it lower. So if they're running a higher heart rate, we'll give our beta blockers for that. So this just tells you how to dilute it, and we can have this available for you. The hydralazine comes in only 1 ml vials. We only give a dose, generally we start at 5 to 10, so you have to dilute it so you have 5 milligrams per ml. And again, just like they taught us in nursing school, if you are giving a medication and you are giving, a medication like that's a high risk medication, you're giving an entire vial or you're giving multiple cc's, and you should be like, is this the right dose? And maybe kind of double check what we ordered type of thing. So labetalol, the only issue too is we have to be careful in asthmatics, smokers, because it can cause bronchospasms. It has one additional receptor that it works on aside from metoprolol, so we just have to be careful in patients like that. So if we order that and they're an asthmatic or respiratory issues, just remind us of it in case we forgot or we're not familiar with the patient. But generally speaking, we order metoprolol and hydralazine. So for low blood pressures, generally speaking, it's our systolic less than 90, MAP less than 60. We'll do phenylephrine and ephedrine. Again, we choose these by heart rate. Phenylephrine will decrease your heart rate, so that we will not give you unless the patient's heart rate's 70 or more than that. And again, you'll have to dilute that. We have how to do it here. Right now we don't have the syringes, so you have to double dilute this medication. So you should be doing 2 dilutions, and it has it here. And if you have any questions, we can either do it for you or walk you through the first time. Ephedrine will increase your heart rate. Again, you'll have to just do a single dilution for this medication when we give it. Do you guys have any questions on these medication stuff? We've all probably given at least 1 or 2 of one of those. Yeah. So any cardiac issues, just follow ACLS guidelines, like severe bradycardia, symptomatic or not symptomatic, just follow ACLS protocol with the atropine. High heart rates, if you think they might be an AFib or have some other dysrhythmia going on, you can just call for an EKG, let us know, and we'll further test and get the cardiologist involved in things like that. And then this is just with us working together. Just call us sooner rather than later. Even if we're in a case for a long time, just call us. We might know who is not in a case and available, because a lot of times if we're not in a case, we're not here, we're somewhere else, but we could be here. So just let us know and we can try to get someone here as fast as we can, or we can keep talking with you over the phone of what to give and what's going on. Questions about any of that? It's just kind of a refresher on all that stuff. Okay. Thanks guys.